So we can go live now. So we are live now?
Yeah, Dr. Divya, please start. Yeah.
Hi, good evening, everyone. So we'll start with the webinar today, which is covering the complications related to Ilizarov method. So we have different speakers. I will introduce them as we go on. And we will start with the first presentation, which is just a guideline on to identify and prevent any complications which we see with the Ilizarov. So this is just a case to highlight what people often consider as an Ilizarov fixator, which has been applied here without following any principles of reduction. And so just placing wires doesn't mean Ilizarov fixator. And this is a second case. If we can see the video here, the wires are all loose with the wire fixation bolts connected, and the wires are not tensioned even. So this is not Ilizarov fixator, and this cannot be considered as a complication of Ilizarov, because the givens in OR for a good Ilizarov fixator application and following the methodology is a proper pre-op planning, following a surgical tactic, having a stable fixation with near and far fixations, maintain the alignment, and that is the correct alignment, and construct your frame accordingly with the anatomic considerations and soft tissue respect. Now, having said that, all taken into account all the givens in the OR, still complications or issues can happen. So here is to highlight few of the issues usually encountered. The commonest is the pin site problems. Most of these pin site issues are preventable by proper pin site care, proper introduction of pins during while inserting the pins, following a start-stop technique, and showing an example here of ring sequestrum, which is formed because of the thermal necrosis caused during drilling. Now, as we speak often during the workshops and even other seminars and webinars, that a start-stop technique and using a sharp drill bit is must. So when a situation like this does arise, one needs to curate that out and take out that sequestrum, and the pin site will settle down. While inserting the pins, at the end, one should ensure that there is no tension on the skin and release the skin tension immediately after insertion. For example, over here, this pin site, this skin where the pointer is tented. So just go along the pin and make stab incisions to release that pin site. And sometimes when you're lengthening or doing angular corrections, the pin site initially, which was not having any tension, may develop a pin site tension because of positioning or due to that correction. So that release can be done in OPD just by giving local and using a stab knife and cutting the skin. This will avoid pain in the pin site and avoid any pin site infections, which can then later on lead to pin loosening. So one can share such a video if you have one, or you can share Dr. Mangal sir's video on pin site care. They should see it and do the pin site care diligently. The method we use is a sterile gauze piece for every pin and use boiled water to clean it, encourage regular bathing and regular pin site care. So these are the healthy pin sites at the end of 6 months, 8 months, or even a year. So it is not impossible to have such a healthy looking skin and pin site. On the X-ray, the healthy pin sites will look like that. There is no loosening lysis around the pins as well. In female, especially because of the soft tissue bulk, there is a lot of skin movement on the pins. So that can be reduced by when you wrap the gauze pieces. What we do is we will ask them to take a couple of hand towels, cut them in half, and sort of boil them and keep them clean, which they can wrap over the gauze piece or between the clamp and the skin to reduce the skin movement on the pin site, which will reduce any discharge from the pin site, and these can be washed and reused. Just a simple method to reduce that skin motion. Now, obviously, this looks infected, pus is coming out, the skin is red, and the pin site has become painful. What do you do when you have? Just don't start right away with the antibiotic. Just make sure the patient is following due care for the pin site care. This is the time to reinforce and check whether they are doing it properly or not. If you find any issues with that, correct that, and then advise them on the antibiotics, as well as encouraging cleaning twice a day till this discharge settles. Usually, just with 7-day course of oral antibiotic, this will settle down. Make sure there's no skin tenting happening, which needs any release or release of any pressure there. So sometimes the infection will go deeper into the pin, and one would need to change those pins or screws. So a continued infection, a large area of lysis seen around the pin, where a pin or wire is not having any further hold in that, and if that lysis is increasing, that is a future risk of a pathological fracture. So those cases, we will change the pins. In this example, where an LRS has been applied, and one can see loosening happening around this middle pin there, and the lysis is almost reaching that end of the shank screw in both these distal pins. And this is when one will encourage a pin change. Now, sometimes there is no infection, but the pins may still get loose. This happens more commonly with monolateral fixators. And when you see lysis happening like that, and this will lead to loss of fixation, which is evident here with the angulation and delayed healing as well. So that is the time then you want to change it, which is what we did at this point. We added, took out those pins, we curated the pin size and sample that for culture as well. Accordingly, you can give an antibiotic which is sensitive to the bug and change those pins and correct the alignment. To correct the alignment here now, to get that compression, we needed to add fibular osteotomy as well. And we added a bone graft substitute also, which allowed us compression. That is the oblique fibular osteotomy, with just that minimal overlap. And then this went on to heal progressively without any further issues. That's him at post removal. So oftentimes, just with positioning with the Ilizarov fixator, one forget about the adjacent joint. Oftentimes, for limb elevation, people will keep the pillows under that leg. So a picture like this in the upper picture, where the pillow is kept all the way proximally up to the knee, that will over time lead to a flexion contracture in the knee, though the ankle is well supported here with that floater and straps to prevent any equinus. So just moving those pillows distally under the last ring encourages maintaining a knee extension as well. So encourage them to use the straps 24/7 to prevent any equinus contracture. Now in this patient, already sort of sent from one department to the other, while she was waiting for the plastic cover and the infection to settle down, an LRS was put on laterally, which is sort of not required at all when you have such a big area available anteromedially to put the LRS. Lateral LRS should be discouraged. Ankle is not supported, and she landed up with the equinus. So that just adds up to another problem which you need to treat. One cannot weight bear, and the gait normalization cannot be encouraged. So this is preventable and should be prevented by using straps. If you are using a monolateral fixator, then you can give a slab with maintaining ankle in foot in the plantigrade position. Encourage active movements of the hip, knee, and ankle. The muscles are crossing two joints.
Divya, you're in question time now. Huh?
So this was 20 minutes.
Minutes. This was Akansha 20 minutes or 10 minutes?
Sir, I was told 10 plus 5, but we can adjust, no issues.
Okay.
So if there is already an established contracture, extend the fixator across the joint and correct that as well. Here, for the deformity in the tibia, the subluxation of the knee was corrected first, and then the tibial correction was sequentially corrected. Similarly, if an ankle equinus is established, correct that as well. The red arrow here points just to the recurvator moment because of the equinus. So the heel ring here is attached to do a 6-axis correction and correct that equinus so that the foot is plantigrade, which will encourage axial compression at the non-union. So for the gait training, again, the equinus is detrimental and it comes into the way of weight bearing. And a painful frame will have issues again because of whether it's a tension pain from the pin side or loss of tension in the wire. We will have a case next following this, which is discussing this more in detail. And a poor unstable frame again will lead to a poor bone formation when you have lengthening which is done or regenerate which is poor. Here, this is a cyst which is formed in the regenerate, and this is a potential stress riser. So one should curate such a cyst and add bone graft. Here we have added a bone substitute, which has then led on to healing. Neurovascular complications, preventable once if you are following the safe zone and follow the mantra of drill through the bone and tap through the soft tissues. This 41-year-old lady, we presented with a malunited proximal tibia fracture, which we were correcting. So the depressed fragment was elevated, screws were added, and we did a fibular osteotomy and correction of the valgus with the fixator. And following this, she kept on complaining of pain and the sort of hypoesthesia, hyperesthesia in the region of the common perineum. So do not ignore those symptoms of pain, especially if there is any change in sensations as well. And here our thinking was because we have followed the safe zone, so we have not impaled any nerve. And these were the differentials we were going through in our mind. And then we did a musculoskeletal ultrasound to confirm the position of the nerve and that fibular wire, which was floating. And that wire was through the nerve. So we went in and removed that wire. That red arrow is pointing to the area where that impalement was done. We also released the common peroneal nerve. And the issue here was probably because of those screws and the altered anatomy because of the fibular head fracture. The fibular wire was passing through the nerve. So most of those complications, I just enlightened a few. I enumerated a few. Most of them are preventable, and spending 30 minutes extra in OT saves hours in OPD with a patient who's complaining of constant any sort of painful issues. Do not ignore their problems and find a cause and handle that. It is not a fit and forget method, and one should be careful, diligent enough, and encourage frequent, regular follow-up so that one can tackle these issues earlier, recognize and tackle them. Thank you.
So we have 5 minutes for questions, if any.
We'll take questions in the chat box.
Yes, sir.
We'll go ahead with the next talk.
Okay, sir. 10 minutes, sir. 10 minutes plus 5.
How many speakers do you have? You have to finish by what time?
So there are 6 speakers, sir. Divya sir is done. We have to
Okay.
finish actually by 9:30.
Correct. So what does that lead to?
I think we'll be in time, sir.
Okay. 5 speakers, 15 minutes
Yes,
each.
sir.
Okay.
Who's
next?
The next
Girish is
speaker,
next.
Any questions can
Girish,
come in the chat
Nathani.
box and we'll answer as they come.
Yes, sir.
So Dr. Girish with case of painful frame.
So can I start sharing my screen?
Yes.
Thank you. Good evening, everyone. So the topic for today's talk would be painful frame. So this is a patient who was 21-year-old male. He had a road traffic accident in 2023 October. External fixator was applied, and after 1 month, a skin grafting was done. And after around 1.5 to around 4 months, the LRS fixator was removed and Ilizarov fixator was applied. The patient specifically gave a history that he was absolutely not able to walk after the Ilizarov fixator. So this was a post-op X-ray, which was done elsewhere, and there were some issues with the fixator. The major issue was there was a single rod which was connecting all the 4 rings, and that rod was bent. The rods connecting between the rings were not equidistant. Yeah. So as you can see in the last, the third and the ring between the ring 3 and ring 4, there were only 2 rods which were connected anteriorly, and there was nothing posteriorly. Similarly, between R2 and R3, there was nothing which was connected anteriorly, and between R1 and R2, there was nothing posteriorly. The rings were also translated, and those were tried to adjust with the single rod. Hence, the rods were getting bent. And there was no use of any coupled washers anywhere. Even though the rings were angulated, the coupled washers weren't applied, which resulted in a very unstable frame. And we can see that there was a wire fixation bolt which was attached over here, and there was no check nut. So that meant the wire fixation, the rancho cube were very loose. So in the video, we can see the rancho cube was not very securely attached with the ring. The wires which are there were also not tensioned adequately, and there was arcing of the wires. And on the X-rays, we can see that he had a valgus deformity and a recurvatum deformity at the fracture site. So this was 6 weeks when he came to us, and this is how he was walking. So he was not crossing over properly. He was just keeping the foot on the ground and trying to just hop around on it. So we decided just to change the tensioning of the wires and realign the bone fragments. So we took him into the theater. We tensioned all the wires. We didn't add any wires or changed any wire or screw. Just tried to realign it, and then we fixed it with the straight small rods connecting only between a single fragment. So the R1 and R2 was connected with straight rods, and we had specifically used these coupled washers, which help in adjusting the angles between the rings. So even if the rings are not perfectly parallel to each other, the rods will distribute the stress equally between them. And then we added these check nuts onto the rancho cube so that the ranchos are securely attached to the rings. While doing that, we also noticed that one of the wire was transfixing the muscle. So it was going from anteromedial to posterolateral. So we adjusted the fixator, corrected the angle, and this was the full length X-ray on the left side is after the adjustment of the angles, and on the right hand side he had a 12.7 degree valgus deformity. So this was immediately after the fixator adjustment. He was able to walk pretty much okay. We taught him how to do crossover walking, and he was putting full weight on the leg and walking. And these were his sequential X-rays at 1 month, 2 months, 2.5, then 3 months. So as we can see, there was progressive healing at the fracture site. Although the contact was a very conical or a very point contact, but it was still healing. So at around 3.5 months, we saw him again, and the fracture site was healing, but we wanted to increase the girth of the fracture site. This was his walking video at around 3.5 months, and he was walking unassisted at that time. So as I told you, we wanted to increase the girth. So we decided to go ahead and do a iliac crest bone grafting to increase the girth of the fracture site. And this was his post-op X-ray. And these were his serial X-rays for 3.5 months, in which the girth, the bone graft was amalgamated, and the fracture, the circumference of the fracture site had increased. And this was at fourth month post iliac crest grafting when we decided to remove the fixator. So we did a stress test. He was made to walk with the rods disconnected between R2 and R3, and he was walking very comfortably. So we decided to remove the fixator and gave him a cast for some time so that it is well protected. And this was 1 month post fixator removal. After that, he lost to follow-up and came back to us after 5 months with this cast, which he had broken it from the sole end. But he was walking very comfortably. And we did the X-ray and we found out that the circumference had increased and he was completely united. So my take-home message would be that for a Ilizarov fixator, tensioning of the wires and the pins are very important. The fragments has to be properly aligned so that it is healing. And a good post-op rehabilitation is very important so that the patient can start mobilizing early and he can do his exercises and doesn't lose his muscle strength. Thank you, sir.
Okay, so just go to that go to the loose shan screw slide.
Yes.
Yeah. So here, what he's pointing out is just play that video again. Just go back once and come back forward.
One second, sir.
One more, and now forward.
Yes.
Yeah. So if you don't have a short bolt, then you have to use a check nut in that, because if you don't use the check nut, then this is what happens. The bolt, so normally we say fix the bolt to the ring and then, fix the rancho to the ring and then the shan spin to the rancho. So when you are fixing the rancho to the ring, your bolt should not protrude inside. Otherwise, you get this kind of fixation. And of course, tensioning of wires, the moment, as you see in the red arrow, you see wires which are bent like that. That is not a stable fixation. So you could have saved time, Girish,
Yes, sir.
by doing a grafting.
In the first stage.
May not be in the first stage, but earlier, because we waited for 3 months to get it healed and then again another 3 months after the grafting. So if you have point-to-point contact like that, even if it is stable, the moment you see that it is not broadening, then there is a role for considering grafting so that you can get. Right. Okay. Any other questions? Ruta is not joined?
Sir, sir,
Lab
Manish,
is available, sir.
Huh?
sir,
Yeah, Manish, go on.
sir, I just wanted to ask you one thing regarding this bone grafting. I had the same thing in mind that it could have been done earlier, because later when the things consolidated, then it would require a lot of freshening and taking down of the consolidated bone and packing the whole graft there, isn't it, sir? So
Not really freshening, it's more of decortication or roughening. Yeah. So
decortication,
you're not affecting the union, you're just
sir.
decorticating and getting fresh surfaces on the bone rather than fresh ends of bone.
Right, sir.
So yes, that point is valid, that if you have a thing like this, either you are willing to take the risk that, okay, if it breaks, it'll break.
Sir.
Or what I would prefer is getting a larger cross section so the risk of fracture is less.
Sir. Yes, yes, sir.
Amar, anything to add?
means we could have refraction bone ends and do a corticotomy. It means gap would be very less, say around 2 to 2.5 centimeter only. But on
Yes.
same stage, we could
He
have.
had a problem with the skin, I think, over that area.
Mhm.
That is why they decided to
Mhm.
that the skin over that area was not terribly
Mhm.
good. So that is
And-
why they decided that we will not do any more. Was this a patient from JJ? This was a patient from
Cooper.
done in a public hospital,
Mhm.
and we were just trying to help them out. So there's no
Mhm.
what do you call, no cost and all that. So
Yes, sir.
they had created that
Mhm.
frame, and then we were trying to help them out by modifying it this way.
Sir,
But
I
yes,
had
that
a
is another option. What Amar said.
Yes.
Excise those thin areas of bone and compress it. So that will give you maybe 2 centimeters of shortening,
Mhm.
and you can lengthen it from a separate area.
Yes.
sir,
Second thing, this
one
protruding pin in second means what I generally do is whenever such thing has happen, we can change to different pin. Means in R2 there is a pin which is protruding way ahead longer than
Yes,
yes.
true.
Hmm.
Yeah, Manish, you were saying
Sir,
something?
yes, sir. Another thing, sir. I had a patient of Ewing sarcoma, sir, brought to me from elsewhere. He had already undergone his treatment. And what had happened is that because of radiation, and then they had taken out a segment of about 12, 13 centimeters of the tibia, sir. So when I had to manage that gap, and naturally I had to transport the whole thing, I did. Sir, I found the bone suddenly tapering at the lower segment, which I had to corticotomize and take it up. So I removed that tapered part and another 2 centimeters below that also, thinking that the tibia will go back to its the normal shaped tibia will start getting transported. I mean, and getting the regenerate. But to my surprise, sir, the whole thing still kept on moving on like a pencil thin cortex, sir. Matlab, it was quite thin as compared to the normal tibia. And then I allowed it to go ahead. Then I had to plate it and then support it, sir. Subsequently, once it dogged.
Yeah.
So I had faced that situation, sir. It never came back to the original width of the tibia.
That biology was already
Yes, sir.
disturbed.
Hanji, sir. Yes.
True.
Thank you. Sir.
And the point is that if you have something like that, then you should be ready for changing over or switching to internal fixation to protect that regenerate. I think recently on the WhatsApp group also we had something similar which someone had put up.
Yes.
And these post-irradiation patients are not good candidate for bone transport. So a fibular transport would be a better option. Just my view.
Femur, I had a similar case in femur, sir. The girl did very
I
well.
thought it is tibia.
Yeah, this was tibia, sir. The one
Yes.
which I told you about was in tibia. The other one was femur, same 13-year-old girl, even sarcoma with almost 15 centimeters gap. She did very well. This boy had a tapering bone, sir, which followed. Sir,
Oh.
sir. Sir.
Thank you. Next.
Right, sir.
Who's next? Kuldip? No, Mehul.
Yes, sir. Good evening.
Mehul.
Go on.
Yes, sir.
So meanwhile, there was a question for pin track care. Can we go for washing with normal soap water during routine bath? Divya has answered yes, encourage for regular bathing, but pin sites should be cleaned by boiled and cooled water separately after the bathing. Go on.
Yes, sir. Good evening, sir. There is a patient, 40-year female patient. He had history of road traffic accident in 2024. She had open fracture 3B, distal tibia fracture, which was primarily managed by the X-Fix and daily dressing. And I did Ilizarov 2 weeks after the injury. So this is a simple spiral oblique fracture, and just a 0.5 to 1 centimeter exposed bone, which was fixed with the X-Fix, and I did Ilizarov surgery. So at the initial time, where I believed that in every open fracture bone should be excised, and whatever amount of excised replace or restore with the bone lengthening. So I did this, just 2 centimeter bone excised, and I did corticotomy for 2 centimeter lengthening. Translation in the lateral X-ray, which was corrected with the Defix, which converted with the rod, and this is a distraction phase. 10 days, and this is the left X-ray. Right X-ray is around 4 months after the corticotomy distraction. APN lateral view. There is no any callus formation. So I compressed right.
Command Elmer.
Just
Thanks for the opportunity for other things.
yes. So this exercise is 1 month after the compression. So looks good. There is some amount of callus seen in the lateral cortex and posterior side. And this is 2 months after the compression. Patient is walking slowly without support, and this union is seems like dicey. That I'm not sure this is united or not, but there is a 7 month till the fixator time. So a patient is fatigued from the fixator, and I just removed the fixator, and after removal, even after removal, patient is walking for 1 or 2 months. But this 2 months post fixator removal, this bending starts from the corticotomy sites, varus and procurvatum. At that time, I advised for the plating. Plating was done with the correction of varus and procurvatum, and at that time, multiple drill hole at the non-union site. This is internal plating. Again, which was infected at the plate site, which was managed with the regular dressing, but in distal wound is not covered. But infection cured, but by the dressing, but implant loosening and varus collapse. So there is a loosening of the screw, and again non-union at the corticotomy site. Varus and procurvatum still exist. And at that time, I explained for the re-Ilizarov, which is most cumbersome part of a Ilizarov surgeon. A patient took another 8 months to take decision. And after 8 months, I applied re-Ilizarov, opened the opened the corticotomy site, and wedge was removed to correct the valgus and to remove the fibrous tissue.
Hello everyone.
Site, corticotomy site, and a static frame was applied in valgus. 3 months, the fracture is nicely united, APN lateral view. At the 3 month fracture was dynamized. A patient is walking unaided. There is a valgus alignment. There is a 2 to 3 centimeter of shortening, but which can be compensated by the shoe raise. This is at a time of fixator removal. This is the clinical stress test. And this is the after removal of the fixator. Sorry. So journey from April 2024 to July 2026 means 27 months. There is a lot of complications that learn me lot. Never be a greedy, as we are Ilizarov surgeon and we can do lengthening whatever amount of the short. So if I accept 2 centimeters shortening on day 1, patient would not suffer. At the time of frame removal, I would apply a plaster or supracutaneous plating to avoid the collapse, varus collapse. And at the time of plating, I would put a bone graft also. In the complication, stick to the patient, do whatever you can because it's your complication and patient suffers. It's our responsibility to correct our complication. Thank you.
So now you have not told us the most important thing. Why did this happen?
Just so corticotomy and this is my initial first case that corticotomy site non-union had occurred. But retrogradely, I thought that maybe corticotomy, if I put a bone graft at 4 months or 5 months.
Wo chodo. I'm saying why should a corticotomy go into non-union?
So that I don't know.
Touch wood, I have not seen one as yet. I have seen patients where one side of the corticotomy is not healing or there is a cyst. So I have probably at least about 8 or 10 patients that way. But where the corticotomy has not formed bone at all, I don't remember seeing that. Amar?
I had said a similar case of a lady who had no regenerative corticotomy, but it was an open corticotomy with giggly show, and means there must be a lot of trauma at the time of doing corticotomy. But low energy corticotomy by and large doesn't have this issue. And second thing that we could have waited more time in a frame. If frame would have been stable and pain free, then patient would be convinced for keeping frame for little bit longer period. I feel.
Patient was already, she said, patient was
7 months
fatigue.
in frame.
Yeah, frame fatigue. So
Frame
if a patient has a frame for 7 months with this kind of a picture and below it's healed, even I get frame fatigue.
Agree, sir.
My point is there. Then what was wrong with grafting that non-union side early on itself? If you find that it is not healing or giving a protection later on, when you before you take it out. Generally how I look at grafting is if the fixator is expected to be removed in about 6 weeks, 8 weeks, and if I'm not convinced about healing at either one of the sites, the non-union or the regenerate, then I will consider whether I need to graft it now so that the fixator removal is not unduly delayed.
Yes.
And I usually explain it to the patient that way, and most patients understand. There are two other questions on the chat. Chirag is asking, excellent learning case, Mehul. Any particular reason you didn't prefer IM nailing and soft tissue cover after the primary injury?
That can be done, but there is an exposed bone. If I would a choice of the nailing, then flap and X-fix for and excision of the exposed part should be taken around 4 to 6 weeks, and then nail can be done. But there is a little higher chance of infection in rather than closed fracture.
Another thing is that previous pin track near corticotomy site means pin track of external fixator, whether they were clean or there was some element of infection.
Yes, Ilizarov is always better, sir.
No.
No. After you
Before
did the exchange plating, no? That time when you took out the fixator, were the pins infected?
No, sir. That's why I did the internal fixation.
Okay, then why did the internal fixation get
Sir,
infected?
I'm asking about when patient was initially in external fixator.
Oh, okay.
And then you put a frame. So even means we should avoid corticotomy in near this infected pin track if it was there. Just it is a query, means it may not be there.
This osteotomy was higher than that, but yes, the point is, if you have an intramedullary infected nail, that's another reason where you can delay the corticotomy.
Yes.
Instead of confirm that the infection has settled. Kota Aditya says, primary Ilizarov ignoring the wound. Can it be done if this case presents to us now? Yes, but there was exposed bone, which is why he excised the bone, is what I'm thinking. Is that right, Mehul?
Yes, sir.
And putting on Ilizarov in spiral fractures can be a little bit dicey. So if it becomes transverse, it may not be a bad idea. So,
Sir, I have one question. If this wound and this type of fracture comes now at me, so can I do just excise those those bone which is infected and put a Ilizarov in situ?
Means if that part which is excised is less than 1/3 circumference of bone, you can surely do that, and at later stage when things settle, you can opt for bone grafting.
Okay.
Sir, so regarding the non-union at the corticotomy site, sir, can there be any other reason? Is there any other known reason other than maybe a very high velocity drill or some kind of thermal necrosis which would have.
That's why I'm asking Mehul, because Mehul is well trained.
Sir.
So he would not be doing a rash.
Correct, sir. Correct, sir.
osteotomy.
Or maybe some metabolic problem with the patient itself, sir. We many times, it is not really needed every time. The second time it united in the same Ilizarov. I mean, in applied differently, but mostly that is what, sir. I just wanted. I was wondering, sir, if there is any other cause.
Yeah, Aditya is asking too rapid turning. That would be unlikely because the patient would have been trained. This was what, 1 millimeter per day, no?
Yes, sir.
Yeah.
4 times a day.
Yeah, 1 millimeter a day is what was done. All right, good. So this is something that can happen. Let's go to the next case. Aditya says, I don't think primary excision on day 1 is needed. That depends. What I can see on that picture which he's showing. Let's go on to the next one while we're talking. Who's the next person? That picture which we are seeing, Aditya, there I can see exposed bone. If that bone is dead, keeping it there is not necessarily a good idea. And as Amar pointed out, if it's less than 1/3 diameter, you can take out that dead bone without creating a problem with the stability.
Okay. Next is Aditya Apte.
Yes, I'm sharing. Good evening, everyone. I'm Dr. Aditya Apte from Thane. So this is a 22-year-old male. He presented to me like this. Initially, he had a proximal 1/3 sharp femur fracture for which a standard femur interlock was done. Then, because of malreduction, the femur interlock was changed to a long PFN by the primary surgeon. And then after that, he presented to me like this. So he was full weight bearing when he presented, but he had a sinus. Because he was full weight bearing and on the X-ray, the nail was looking loose. I was not very sure whether it's united or is not united. So I took a CT. On the CT, the report showed that he had union along the posterolateral aspect. So I explained to the patient that this will require implant removal, and then if it refractures, then we'll go ahead with Ilizarov. So in the first stage, that was what was done. We removed the implant, and this is the intraop video. Intraoperatively, after removing of the implant, there was It felt like it was completely united. There was no movement at the fracture site, even on rotations and flexion extension. But as expected, at 6 weeks, after the patient started full weight bearing, it broke. And then I changed it to a Ilizarov. So on again re-exploration, around 10 to 11 centimeter of bone was removed, and distal corticotomy was done for the lengthening. So this is the bone transport. The bone transport went relatively uneventful, and this is at the end of 11 months. So these are the final X-rays before the clinical testing was done. As you can see on APA and lateral, the anteroposterior and the medial cortex looks okay. So I removed the after clinical testing under the C-arm also. I removed the Ilizarov at about 1 year. So these are the images after Ilizarov removal. And this is a scanogram. The limb length was all right, and the axis looked okay. Slight valgus, but it looked okay. Now we went back to UP. He was from UP. At about 2 months post-op, when he was getting down from the bus, he had some severe pain in the thigh, and he called me. When he took the X-rays, this is what was on the X-rays. The regenerate had fractured centrally. So now at this point, the only two options were we either put a long plate, but I was not sure considering the bent, the procurvatum in the distal femur, will I be able to put a long plate? So I went ahead with the revision Ilizarov. I did not do any correction, any major correction. I just put the similar frame proximally and distally. And at about 6 to 7 months post frame, this is the X-rays. I have removed the frame last month. So this is him walking. He's walking all right, no pain, but the knee is stiff. I have started on CPM and gradual knee ROM. Currently, he only has about 40 to 45 degrees of knee ROM. So the take home for me is, firstly, the CT probably cannot always be trusted. It is always, as everyone says, it is always advisable to remove the Ilizarov 1 month or 2 months late rather than early, and always advisable to start early knee ROM from post-op day 1. Thank you.
Thank you. So just go back to your first after removal. Yeah, that fracture after removal. Why not put just this was already healed, right?
Yes, I mean, even clinically, it felt like healed. He was walking.
Correct. So when he fractured, why not just put on a Ilizarov in this position? Why did you excise so much bone is what I'm asking.
Sir, I was not sure about the integrity of the bone. I thought that if it has fractured once, it can always fracture again.
But if it has fractured once, due to a mechanical kind of defect, that is the medial side was defective, over time, this could still have healed up enough for it not to fracture. Meaning, we had this sort of discussion, I think even a month ago when Rama Karthik had shown some patient where he excised quite a bit. Now, I would be very wary of excising too much of bone. Let us say that, okay, that medial aspect is not good, but the lateral aspect has definitely healed even clinically, which you were showing.
Yes.
And on CT.
Yes.
So whether to just protect it for a little longer, even slightly more controversial would be let him walk on the nail. He has a discharging sinus.
Yes.
As long as his CRP, etc. is okay, and there is no progressive destruction of bone, we say the bone unites in spite of implant or in spite of infection. So another 3-4 months, his thing could have healed up better, and then we could take out the implant. That is also one of the sort of ways of looking at it.
Sir, if I may, sir. So this is a fairly common scenario, this particular X-ray after the implant removal or something. So in general, at our institution, sir, though we are doing everything, we would have had done two things, sir. Just sharing our protocol. I would have gone for some exchange nailing with some KNL antibiotic cement spacer for maybe two times, sir, in within 4 to 6 weeks. That is one, sir. And we would have hoped, because this excision must have been done in view of the previous speaker's apprehension that there would be infection, isn't it? So that thing could have been taken care of. What you just said, sir, that an Ilizarov could have been simply applied without excising that much. I probably might have gone with an LRS also here, sir,
Yeah,
in order to make it more comfortable for the patient. Or, sir, or maybe he would have been actually protected, as one of my hospital colleagues has written on the chat box also. We could have given an HKFO or something and protected him, waited for a few months. I'm just contemplating, sir. Whatever he has done, he must have done in his own wisdom, and he would have thought right. But these are options which I thought I might share, sir. We would have done one of these three things. I would have done rather. So it's a fairly well aligned bone. 2-3 times you could have exchanged with a KNL cement spacer, and then maybe you could have left it like that, or you may not have required to do anything. Maybe there are options.
Yeah, so these are all the options. Again, Chirag Manwani has said, would you consider thorough debridement, local antibiotics like Stimulan, and renailing with the understanding that the nail might need to come out at a later date once the fracture heals? So this is something similar what you just said. In terms of, you can consider an antibiotic nail also. That is also one of the options. I had a patient recently, a lady physiotherapist, who had discharge from the proximal site, not from the fracture site. She had from where the screws were put in, the proximal 2 screws into the head. And we kept her, but her bone was not solid. So she had a little discharge. Her hemat was all okay, not going more than 12, 13, 15. So, and she was relatively asymptomatic. So we just kept it on, let it heal. In this particular case also, I would have, see, one of the knee-jerk reactions orthopedic surgeons have to some amount of discharge is, oh, all of this has to be excised. No, I think you can allow some time, as long as the CRP and all remains okay, patient is asymptomatic, and you are not seeing increasing destruction on the bone, in the bone. There is, I think, a role for wait and watch, right? What is
Absolutely, sir.
masterly inactivity.
Sir.
So these are all the things that can be done. Kuldip has said reinfection chances rise from 20 to 40%. In what case, Kuldip? Yeah, I say हवा में छोड़ दिया है, 20 to 40%, not 20 to 39%, not 20 to 41%. ये साला हाँ?
No, when I was given, sir, this infection back in 2020. This is from AO's reference point of view. When there was an infection and you apply internal fixation, thou of the debridement and everything, there are chances that it will reinfect.
That is a given, but तूने ऐसा लिख दिया है कि 20 to 40%, मतलब खत्म हो गया बात. 39% नहीं हो सकता है और 41% नहीं हो सकता है. चल.
The same AO says that the treatment of infected non-union of shaft femur is exchange nailing.
गोरा होएगा तो सही है, ऐसा थोड़ी है हमेशा.
हाँ जी सर.
चलो next.
Aditya, you can stop sharing. Kuldip.
Okay, sir. My screen is visible, sir?
Yes.
So, Ilizarov in cancer patient. So this was a male 36-year-old, have proximal tibia giant cell tumor and was treated at GCRI Institute with almost upper third tibia resection and came to me. I do not have the pre-op X-ray, but you will get the idea that almost proximal half of tibia has been removed with leaving the distal femur. So I just applied an Ilizarov frame from distal femur to mid tibia to distal tibia, and then did a distal tibia corticotomy. Initially went on with 0.5 millimeter per day, and then up to 0.75 millimeter per day. The gradual transport, as you can see the progression. And when it came for the docking, the rings were, the legs were so edematous that it was cutting the posterior half. And even patient got also tired because the rate was slower in the distal corticotomy side. So I had two options. I could change the ring to a larger diameter, or I can apply the rail fixator. I am compatible doing both. The rail thinking of applying rail fixator was that he will not be having ring fixator. He will have a touching posterior aspect of leg, and he will think that something new is being done. So I just removed the rail Ilizarov fixator, applied anterior rail fixator for the healing of regenerate as well as the union at the tibiofemoral junction. So that is a total 16-month duration. That is at 18 months. Yes, there is some void or maybe cyst in the regenerate side. So I am protecting it with the brace. Yes, he has got equinus. He was not ready for that another ring into the heel. I could have applied in the initial surgeries as well, but he's okay with equinus, and raise is being given for the same. So it is like we don't learn swimming until we dive. So complications, the pin sites as well as ring insinuating within the skin can happen, but you always have an option of Ilizarov ring application, or the sufficient bone segment you have, one can apply a rail fixator as a bailout. Thank you.
So the complication here was swelling.
Yes, sir. Yes, sir.
Okay. So there was a question a little earlier. I forget who has asked it. Viprajit Roy. How to tackle gross soft tissue skin invagination in the docking site while doing transport in the tibia? Did you have any invagination here?
I had invagination, but I was I could open and freshen it, the site, and dock it.
So and go on.
And twice a time, what I had happened when longer transport, when there is many invagination, I let it allow the invaginate the skin. There will be actual skin beneath the transport segment. These ends are connecting, but there can be a hollow, and the bones are just skin is being open and bones are just attached. Because we are not putting any internal thing, it is on the external ring, it heals. Even though the bulk of the skin and muscle mass remain posterior. So that does not look cosmetically good, but does not affect as well, sir.
Okay.
So yes, you have a plastic surgeon, one can actually open everything, get a good flap surgery and then do. But if that is not facility and very peripheral rural area, one can consider just opening and get the bleeding bones in contact. Even that you manage.
Yeah, Divya, you can
not
just
cosmetically.
Divya can pull up your bone transport, what to do, so that somewhere when we have time, those 3 slides you can just show. Now, I have one thing that I have learned, Kuldip, that this equinus, if patient doesn't want it also, I want it. Because especially for my healing, so I don't give that now. I don't give that choice to the patient.
Okay.
Why? Because if the patient is walking with equinus, one, they are not weight bearing properly. And
Yeah.
second, when they weight bear on an equinus foot, they are applying a sort of angulatory force on whatever healing has occurred. So if by chance some equinus has occurred, I will give them a shoe with a wedge, that is a higher heel, so that there is no force on the angular force on the regenerate. But
Anterior.
I would generally try to get that equinus corrected, because I know that if I don't do this now, in the future I'm going to have trouble.
Yeah, sir. Yeah.
Dr. Kuldip, did you sorry.
Sir, Dr. Minister, please continue.
नहीं सर, आप बताइए सर. एक ऐसी sir, a small question to Dr. Kuldip. I might have missed it. Did you have to do freshening at the time of docking, even when you were applying LRS?
No, just opening the skin, sir. The distal femur is more of a epiphyseal and metaphyseal region, too much bleeding. And with this much transport, the vascularity in the transporting fragment, you might have also come across. It is tremendously vascular. You just need to, if it has not been transverse cut during the time of primary debridement or so then one has to do. But
initially
there are chances.
initially when the bone excision was done, the femur was not touched, na? It was only the tibia which was taken down. And so
Yes, sir. So it was almost just roughening of the cartilage probably at the site of docking.
Okay.
Not much.
So you didn't have to do any secondary procedure after it docked. It united on its own. Okay,
Yes,
that's it. Thank you.
So my point was, whenever we do a distal to proximal transport, we should always put a footing in a large transport. The rationale behind that,
true.
basically we are shifting a tibialis posterior origin from distal to proximal part. So it is always better to have footing. If not, then patient should have a footstep attached constantly. And even with footstep, it is likely that patient will develop this equinus. Second thing, when such large gap is there, you can offer some amount of transport from femur and some amount from tibia. So that will make your job easier. Third thing, that ring at the level of middle that femur only. In this patient, you have not faced problem, but peripene fracture are very common when femur frame is not extended up to higher level. So here you have not faced the problem, but if patient would have say trivial fall or slip something, then chances of peripene fracture are there.
You're talking about the femur fracture, right?
Yes, femur. So
Femoral frame should extend higher up, is what you say.
Another thing is,
true.
All
This happens.
All patients should be taught to lie down in a prone position for 6 to 8 hours when such large transport is going on. So that will reduce your chances of swelling. So you need to teach patient initially when patient is under your care during surgery, so that he will continue to follow while he is at home also.
True, sir. True.
Right. So I think those points. So one is larger rings whenever you're doing transport, because edema will happen lying down in the prone position. And if it does happen and the skin is biting in, what you can do is put something like cardboard between the skin and the ring as a temporizing measure, so that there is no edge necrosis, that pressure is distributed around the sort of surface of the cardboard. All right, thank you, Kuldip. Next.
Last point, that we can change the ring even without taking patient inside theater in dressing room, a larger size ring.
Yeah.
Okay, sir. Okay.
Next case, please.
Kuldip, can you stop sharing?
He's already stopped sharing.
Okay. So good evening.
Two things I want to say. NMC has said that if you show patient details, theoretically you can be have trouble. So patient names should not be there, And when you're showing videos and all that, patients recognizing factors should be blurred. So Kuldip, that video which you showed, if you notice when we are showing videos, we try to see that we have some circle or something, or we crop the image. So patient should not be identifiable in your presentations, even if you have taken their permission.
Okay, so
So I'm presenting a case of a infected non-union in a 29-year-old male. He presented with this X-ray. He has undergone multiple surgeries, 9 surgeries in total with different surgeons. As such, he doesn't have any comorbidities. So these are the clinical pictures. So he has got 5 discharging sinuses. At a sinus, a small portion of bone is visible. So these are few X-rays of his previous plating. And after the plating, he underwent an Ilizarov, and some distraction at the osteotomy was done, which was significantly angulated. And after this Ilizarov, a fibula from opposite side was used, and he was plated again with this large amount of iliac crest bone graft. And he presented with this clinical picture. So looking at this, I kept both the Ilizarov as well as LRS in the surgical theater. And I found the fibular graft was looking vascular. It was red, and it was well healed with the distal fragment, although there was no healing with the proximal one. So I removed the loose pieces of bones and telescoped the fibula into the proximal one and applied LRS, as I thought the closure was very tight. I remember I used different techniques to get it closed. So I was thinking it will undergo into a necrosis of the margins and might require a flap. So I deliberately put LRS over here. So these are the pictures. He grew Staphylococcus aureus in the culture, and I compressed that to some bit. The margins were relatively okay at the end of 3 months, although there was some discharge coming out from near to the middle clamp. So the flap requirement at present, I thought it might not be required. So as I compressed, I noticed a fracture in the fibula over here. And then I thought of compressing it, and I compressed it by about 4 to 5 centimeters. This is at 6 months POD. I thought he's showing some healing, but on the oblique views, there was actually no contact. So the APN lateral views were quite falsely leading to me, but there was no actual contact, and he continuously had on and off discharge from one of the sinuses. He used to get one new sinus every time, and the leg was quite crumpled up. So at this point, I took an opinion with the plastic surgeon, thinking of opening it and debriding it, everything. But due to crumpling and swelling, he asked me to distract it to get some length so that the flap would be easier to put on. So I distracted the two ends, and at that point, the plastic surgeon had did a cross leg flap. At the time of division of the flap, I did a distal tibial osteotomy, and I started with the bone transport. At this, the wounds were absolutely dry. The pin tracks were looking good. And this is at the end of completion of the bone transport. He started to show some equinus deformity over here. I continued lengthening, the equinus increased, and he was still short by about 4 centimeters, and he wanted the leg length to be equalized. So this is the equinus which he had, and you can see the sinuses had healed nicely. The pin tracks were okay. So I shifted him with the Ilizarov fixator. I had an opportunity, hence I grafted the proximal end. I filled in iliac crest in the deficits at the proximal end, and I involved the calcaneum as well as the forefoot, as you can see over here, and I continued the lengthening. I got the leg lengths equalized, When I removed his 4-foot ring, he didn't do much exercises and he developed some midfoot cavus. But I kept it as it is, as he didn't want any further surgery. The wounds were looking good. And these are the x-rays showing a good consolidation. And these are the x-rays just before the fixator removal. It showed well healed in all the views, the fracture as well as the regenerate area. This is how he was walking. It was not very good gait, but with the elbow crutch, he was walking pretty well. But the x-rays showed a very good healing, so I went ahead with the fixator removal. I almost equalized his leg lengths, and these are the x-rays after fixator removal, the clinical pictures, which shows some equinus is still there. The leg is dry, there is no discharging sinus, it is reasonably well aligned. And this is at the end of 6 months. I have protected him in a brace. I have asked him to wear it for a period of 1 year. So the learning points from this was I should have been radical in the first surgery in terms of debridement. I should have removed that fibula. I didn't see the previous screw which was put in the fibula. Probably it was fractured at the same level. I should have involved plastic surgeon initially and did Ilizarov after the flap. So that is the end, sir.
Why do you say that you should have involved the plastic? Why did the patient have? The skin was not bad actually. Meaning there was a lot of scarring and all, but it was a pretty thick mantle of skin that I can see over there.
Yeah, it was thick, but the closure was significantly tight, sir. I remember.
Closure was tight, yes.
Yeah.
But so for that there are many different ways of doing it, which even gradual closure. But the point is that a fibula which was put in avascular.
Avascular.
How did it vascularize? It can't vascularize. So what what you see as what you described as red is the surgeon's hope that this is vascularized and therefore I will not have to do anything more complicated. Uske bagal mein agar if there is infected bone lying there, how can this fibula be
vascular
viable in that sense is my question.
Yeah.
So I think that would have been one of the first. Yeah, Mehul has asked the same thing. So that would be one of the first things, that whatever you are seeing, what you are calling red, no, is the body's mechanism of trying to take out this. It's all the granulation tissue which is eroding the surface of the fibula. And it's not a vascularized fibula. That is number one. Number two, I think I have no objection to using the LRS. I use it many a time. But you can still do the Ilizarov with a plastic procedure, especially if they are doing a vascularized flap. Then तो बहुत अच्छे से होता है. Cross leg flap में गड़बड़ होता है.
Yeah.
But with the Ilizarov, using a flap is not a problem. My point is you may not have required a flap. If you had thought of bone transport to start with, then probably you would not have required the flap. But as Amar pointed out earlier, whenever you are doing a distal to proximal, large amount, 2-3 centimeters, yes, you would have got away. But when you're doing a large amount, then it's going to definitely cause a equinus. So there again, the Ilizarov becomes a important tool.
Sir, 2 comments, sir. One, that I agree with you about Ilizarov versus LRS in this. I am talking from the point of the skin gap, the soft tissue gap. So what I have also realized, and it is a teaching also, that when you tension the wires, the skin gap also reduces. So maybe that would have aided in the closure of the wound, and you might not have required actually a flap by a plastic surgeon, just a contemplation. Second thing is that fibula was definitely avascular, and avascular fibulae, such kind of intercalary graft, are known to fracture under stress. So maybe, sir, what do you feel, sir?
Not
Sir.
avascular, even vascular fibula.
Even vascular fibula, that for that matter, but avascular fibula definitely, sir.
Yeah. So, but here the avascular fibula, if it was a vascular fibula and it breaks, they throw fantastic callus.
Yes, sir.
And
Yes.
avascular fibula does not. So that I think the problem would be in that initial decision making.
Yes.
Can I say, sir, I had landed up similarly as Ajit has landed. The distal
All of us have landed. I
tibia
also have landed up in this kind of problem. Don't worry.
the fibula at one part it is united, so let us not remove more part.
Yeah, my thought
then-
was to, he has already underwent multiple procedures, so I was doing less kind of damage, but
Similar. If
ultimately,
allowed, I can share the image.
yeah, I ultimately it required what it was actually required.
This lalach, I have been subject of this lalach, not when I was younger, even recently about year and a half back, where there was a patient who had a fibula which had been put into the distal tibia and was united on one side. So I said, okay, we might try to save some time. Ultimately, we didn't save any time. We went through the whole rigmarole just like you went. So that happens to everyone. It's just that we have to recognize it, sort of say what we have done wrong, and then next time ensure that it doesn't happen.
Sir, another thing I wanted to say about LRS application, sir, in this case, what I have been doing and I have been finding it useful is that before we are applying the LRS, and if there is a wound like this, it would help if, with the use of some kind of a towel clip or something, if we can hold the skin edges, I mean, a thick skin edges, and try to approximate them. So that takes care of the thing that, if we don't do it, then after application of the pins on the medial aspect, it will be difficult for the skin mobilization. And again, it may cause problems in closure. While vis-a-vis, if you hold the thing initially before you apply the pins, it takes care of a little bit of wound gap, sir. That's what I have realized, sir, and I have been doing it very regularly, and it has been helping me, sir.
Noted. Thank you.
Sir.
Close before you apply the temporary closure before you apply the pins.
Yes.
Right. Next.
So that was the last case, sir. My case was last one.
Okay, Divya, you
Yes,
can
sir.
show Biparat, Biprajit. We are 2 minutes over time, but just those 3 slides you can show. So this is a lot of fibrous tissue.
This
When
was
you
the
move
proximal
that,
to distal transport, and that was the soft tissue invagination. The green arrows are pointing those bone end, which is trying to come out of that scarred skin. So what is usually done is you can excise that invaginating skin, excise some of the bone ends here. This will give you some skin which you can close as you dock it further. At this point, you may also need to add a fibular osteotomy. And this is the picture, and you are able to get a primary closure with the docking. So this is one of the ways. And excessive over here, there was a big soft tissue defect before earlier itself, and this is skin grafted skin. So as the transport progresses, that part is trying to go under the posterior edge of that proximal fragment. So here the plastic surgeon was involved, who suggested a sort of a delayed flap. What is done is this fasciocutaneous flap is lifted, sutured back. Then after another week, it is again lifted through the same incision and sutured back. That just increases the vascularity of the whole flap area. And then you go in and sort of deliver the bone ends. Whatever is plastered, you can take it off, freshen, dock it with the fibular osteotomy, and then you're able to get the flap cover on it. So these
So
are
here
just-
you notice we have put the shank pin through the flap. Just after the flap has been placed, make a stab incision and do. So plastic surgery with Ilizarov is definitely possible. So I hope that answers your question. Otherwise, ask again next time whenever this seminar is there. All right, I think thank you everyone. Thank you, Amar. I'm sorry that
Thank you,
Thank you, sir.
Gupta
Thank
could
you,
not
sir.
be there.
Thank you so much, sir.
Thank you,
Okay.
everyone.
Sure.
Thank you,
Bye
sir.
bye.
Thank you.
Thanks.
Bye.
Thank you, everyone. Good night.
Good night.
Thank you, sir. Stopping the live streaming now.
Yeah, thank you.
Okay, sir.